Hello, this is Dr. Bhaumik, Professor of Pediatrics and Chief of the Division of Pediatric Endocrinology, University of South Alabama, College of Medicine, Children and Women Hospital. I just retired from there. I am also retired colonel from United States Air Force. In my last talk, we have discussed about the congenital hypothyroidism. However, I felt that to complete the whole lecture series in that area, today I will talk to you about neonatal thyrotoxicosis, which is actually a very rare disorder, but uh, it could be significant and may have high mortality rate if it is not recognized and treated properly. This is the little photograph of the Children and Women Hospital, University of South Alabama. And let's start with what we are going to talk about. Hyperthyroidism in infant born to the mother with Graves' disease only occurs about 1 to 5% of infant. And again, among them, only few are seriously affected by severe hyperthyroidism. And we'll discuss about that. Male and female babies are equally affected, and usually the hyperthyroidism is transient and then it become euthyroid. However, sometimes it could be a persistent and life-threatening. Beside Graves' disease, there are very few other causes of neonatal hyperthyroidism, of which notable one is McCune-Albright syndrome, which is an autosomal dominant condition and result from the mutation of TSH receptor and with the autonomous activation of thyroid hormone production, and that is also very rare. The reason for neonatal thyrotoxicosis secondary to Graves' disease is because of the transplacental passage of antibody, what we call TSI, thyroid stimulating immunoglobulin, or thyroid receptor antibody, and that crosses the placenta, and the highest transmission of those antibody from mother to babies through placenta occurs between 20 to 30 weeks of gestation. And TSH receptors are activated by those antibody, and as you know, by 20 weeks the baby's thyroid is pretty effective and also active, as so hyperthyroidism starts from that point onwards. And as a result, there is overproduction of thyroid hormone, and severity of sign symptoms depends upon the balance between thyroid stimulating immunoglobulin and thyroid binding inhibitory immunoglobulin, what we call blocking antibodies. Both of them equally crosses the placenta. If there is not too many blocking antibodies, then obviously the TSI takes over and it makes exactly same picture the way it does in Graves' disease. And infant at risk usually are, there has been report the infant born to the mother of previously affected infant. Now, it is interesting to note that the TSI, these antibodies may remain in mother circulation for years, even after mother's Graves' disease has been taken care of either by surgery, medical means, or by radioactive iodine. And that's the one is sometimes is a problematic because the mother don't have any more problem, but yet has got those antibody which may crosses the placenta and make the baby's thyroid overactive. The most common problem that we see is that mother received radioactive iodine treatment for Graves' disease maybe 6 to 8 months before she conceived, and the baby is born, and the people actually forgot, or the physician, that the mother had Graves' disease since she is asymptomatic for so many months. However, those antibodies are there, they crosses the placenta, and those are the one who uh, has absolutely no warning, and suddenly they have this hyperthyroid state. And also the other situation we see a problem is that the mother just started or developed Graves' disease at last trimester, and so the disease process is very active. Therefore, the placental passage of antibody is also equally effective, and they crosses the placenta very vividly. And these are the things that needed to be considered. Now, mother with Graves' disease may be euthyroid, hyperthyroid, or hypothyroid because of the treatment, but really doesn't matter because the antibodies are the one who crosses the placenta makes the problem, not mother's thyroid hormone status. Exposure to antithyroid drugs in utero can suppress the baby's thyroid gland, and indeed they may be euthyroid or hypothyroid, only to become hyperthyroid after 10 to 14 days. And I personally have seen two patients whose mother was on PTU and other mother was on methimazole, and the baby was born hypothyroid, but in 10 and 12 days they do develop hyperthyroidism. So elevated free T4 and suppressed TSIs and significant TSI antibody titer is most helpful to predict the course of neonatal hyperthyroidism. If the history is well known by OB/GYN doctor, then it is a good idea to obtain a cord blood sample for TSI and TBII antibody if that's possible. One of the condition has been confused or mimic like hyperthyroid states of the baby are the narcotic withdrawal, and their symptom is very same like the one is depicted in this slide. And all those things that we have discussed here are put here: tachycardia, tachypnea, hyperirritability, excepting that they won't have goiter, but they have hepatomegaly and lots of and they don't have frontal bossing or microcephaly, but frontal bossing microcephaly takes long exposure for the fetus by elevated thyroid hormone. So, but otherwise many of the sign symptom that is in the slides can be seen in narcotic withdrawal. So how do you approach this baby? This is just a guideline I put in the slide, but different medical center and the different doctors, neonatologists may have a little bit different approach. So if we consider the baby is at high risk, then it's worthwhile and wise to get cord blood free T4, TSH, and thyroid stimulating immunoglobulin. If those are very high, if TSI is high and TSH is decreased and T4, T3 is increased, and if the baby is symptomatic, then the treatment, in my judgment, should be start right away. However, if the baby is asymptomatic and has got that high concentration of antibody titer, then repeat the free T4 TSIs in couple of days, in 2 days or so, and then if it is still okay, then repeat in 5 to 7 days. And antibody titer could be a determining factor that how long should we be continuing with the measurement of TSI, because if the TSI remain high, so there is no place for comfort, and we have to keep on measuring the TSI and thyroid function, and sometimes it takes months before it come to a comfortable level in terms of TSI. If the baby is at low risk, it's a mild to moderate elevation of TSI and asymptomatic, no therapy is necessary, good observation, and repeat the free T4, TSI and TSH level in couple of weeks until the situation does not pose any significant danger. As far as the treatment is concerned, in Europe, they preferentially use carbimazole, but that's not used in United States. We use methimazole. Carbimazole converted to the methimazole, they are same group of drug, but methimazole is much stronger than carbimazole, and the dose is given here, and it is 3 times a day. And the other treatment that has fallen from favor is propyl thiouracil or PTU, and it is actually used in many of the Asian countries as well as in Europe, because PTU has some advantage because it not only block the organification of iodide to iodine by inhibiting the enzyme thyroid peroxidase, it also encourages or increases the outer ring deiodinase activity, and therefore less production of T4 to T3. And so the peripheral blocking is also considered as one of the selling point of PTU. However, because of the hepatotoxicity and side effect, it has fallen from favor in this country. They usually have significant tachycardia, these babies, so beta blocker is always a good idea to decrease the heart rate. And once the methimazole has been started, one can use Lugol's iodine or saturated solution of potassium iodide, SSKI, 1 drop 3 times a day to block further production, and this should be started, must be started after you have started the anti-thyroid drugs. Many of the neonatologists and endocrinologists have used prednisone, which seems to interfere with the peripheral conversion of T4 to T3 in a very refractive case. So the biggest threat of the baby and when they have very poor outcome, or they might even die because of heart failure. So therefore, multi-specialty consult, not only neonatologist, endocrinologist, and a cardiologist may also be a good idea to make sure that they can start digitalizing the baby in appropriate time, because heart failure is the biggest threat. Thank you very much.